Great. I love this back and forth that we can do with the Zoom without having to jump up on stage and all that. Great. It's my pleasure to introduce the next speaker, who you've already met, Susan Buchbinder. Susan is a professor here at UCSF, but also a major player in the public health department here in San Francisco, where she's led a number of studies of various strategies, especially of pre-exposure prophylaxis now. Also has participated in the AMP studies that you just heard a little bit about. And obviously the area of PrEP is a hugely important one, complex, changing quickly, and without taking any more of her time, introduce Susan to take us through that.
Great. Thanks so much, Paul. So I am going to talk about pre-exposure prophylaxis, and these are my financial relationships, where what I'm hoping that you'll be able to do by the end of this talk is to be able to safely start and stop PrEP, to counsel patients about 2-on-1 PrEP, and to be able to describe new PrEP modalities. So I've divided the talk into 3 sections. The first is the longest, and that's really talking about daily oral PrEP, because that's really the standard of care at the moment. We will talk about on-demand approaches, and then I'll end with a summary of some of these long-acting investigational drugs that you just heard about. So starting with daily oral PrEP, we've had TDFFTC PrEP available since 2012. There actually were data that were presented at the end of 2010 that showed that pre-exposure prophylaxis with TDFFTC worked for men who have sex with men and transgender women in the IPREX study. And then shortly thereafter, there was data available from the Partners PrEP study in serodiscordant heterosexual couples that showed that TDFFTC also reduced HIV acquisition in that population. So in July of 2012, the US FDA gave a licensure indication for TDFFTC for PrEP, and the World Health Organization came out with guidance on pre-exposure prophylaxis for serodiscordant couples, men and transgender women who have sex with men at high risk of HIV. So I have a question to start off with for you. How is it that you start PrEP? Do you wait for lab results? Do you start PrEP immediately, meaning same day? Do you have you not prescribed PrEP or something else? Go ahead and answer. Okay. So we have 41% of you wait for lab results, and another 35% actually do same-day start. So that's great. Let's talk a little bit about same-day starts. These are data that were presented a couple of years ago from the New York City sexual health clinics, in which they took over 1,400 PrEP candidates, and they asked them 3 simple questions. Do you have a history of kidney disease? Do you have a history of hepatitis B infection with chronic infection? And do you have any acute signs or symptoms of HIV infection? 97% of them said no to all 3 questions, and so they were moved into the immediate PrEP arm. And only 3%, or 50 of the people, said yes to any of the questions, and so they were deferred to a deferred PrEP arm. And here's what actually happened. When they had labs drawn then on the individuals, there were only 4 people in the immediate PrEP arm who had to stop PrEP, 2 because they had a GFR of less than 60 and 2 because they were actually HIV positive. So over 99% were able to continue PrEP, having had started it the same day. Whereas in the delayed PrEP arm, they had 7 people, or 14% of that group, actually had a contraindication to starting TDFFTC PrEP, either because of a GFR of less than 60, because they were NAT positive, or they wanted to know that they had hepatitis B surface antigen positivity. And so 14% were not started on PrEP, but an additional 86% who were left were actually eligible for PrEP. However, only 35% of those people who were eligible for PrEP actually returned to start on PrEP. So there is something to be said about a bird in the hand, and that you can start same-day PrEP safely as long as you have close follow-up, you get the laboratory tests drawn on that day, and that you've got very close follow-up so that you can stop PrEP if there is an absolute contraindication to PrEP. So now let's talk about for whom does TDFFTC PrEP work. And if you see on the right, there are men who have sex with men and transgender women. And if you look at the placebo arm versus the PrEP arm in that group, then they had a substantial reduction in new infections. The same thing for people who inject drugs, also a substantial reduction in the risk of infection. And for serodiscordant couples, a substantial reduction in the RCTs. But when you looked at the subsample who were actually highly adherent to PrEP, you saw almost no infections. And so we know that PrEP is really highly effective as long as it's taken on a regular basis. And we'll talk a little bit about what a regular basis means in just a moment. But it's currently approved. TDFFTC PrEP is approved for everyone who is at risk of either sexually or injection-acquired HIV as long as they're 35 kilograms or greater. So there's no absolute age cutoff. So let's talk about starting and stopping PrEP. And this is, as Turner mentioned, a little bit controversial. For men who have sex with men, the growing consensus is that 7 days before is adequate, or actually just having a loading dose with a double dose of TDFFTC PrEP. And we'll talk about that in a few moments, but that's really the basis of the 2-1-1 PrEP or on-demand PrEP. For women, the CDC currently recommends 20 days before, because that's the time that it takes to get to a maximum level of TDFFTC in the blood. But there's a growing consensus that 7 days pre-exposure may be adequate to get to high enough levels in the mucosal tissue to be able to prevent HIV acquisition. In terms of maintenance, women are supposed to be taking 6 to 7 doses a week, and that's because the PK suggests that the level of concentration of PrEP, of TDFFTC PrEP, is about 100-fold lower in the vaginal tissue than it is in the rectal tissue. Whereas men who have sex with men may be able to, from modeling studies, get away with just 4 doses a week, and that it looks like 4 doses a week is approximately equal to 7 doses a week in terms of maximizing protection. I will say that there are data from some demonstration projects that suggest that women may get high levels of protection even with lower levels of adherence. But still, the recommendation generally when we're counseling our female patients is to say this is a pill that you really need to take every day. Whereas with men who have sex with men, you might say, you know, it's good to try to take it every day, but if you miss a dose here or there, it's really not going to be a problem. In terms of stopping PrEP, the CDC recommends 28 days to stop PrEP. But again, I think that there's increasing evidence that for men who have sex with men, you may only need 2 days after the last sexual act. And again, that comes from this 2-on-1 PrEP that we'll describe in a moment, that only 2 days after the last sexual act may be sufficient to be able to provide adequate protection. And that for women, likely 7 days post-exposure is sufficient. So again, for men, it's either a double dose or 7 days before and 2 days after, and for women, it's probably 7 days before and 7 days after. And that's more tenable than telling women that they need to start taking PrEP 20 days before and maintain it for 28 days after their sexual exposure. So let's talk a little bit about transgender women, because there are a number of transgender individuals, women and men, who are concerned that tenofovir-based regimens may interfere with their gender-affirming hormones. So this is a study from Bob Grant in which they took 24 HIV-negative trans men and 24 HIV-negative trans women and gave them directly observed therapy, who were actually on gender-affirming hormones, I should mention. So the trans men were taking testosterone, the trans women were taking estradiol, and they were put on to 4 weeks of directly observed therapy with oral daily TDFFTC. And then they measured both the concentrations of TDFFTC as well as hormones in the blood. And here are the results for the hormone levels. You can see the plasma estradiol before and after PrEP on the left, the plasma testosterone on the right, and we've got the transgender men and the transgender women in each of these categories. And what you can see is that before, baseline is blue, red is the 4-week data. you can see that there's essentially no change at all in gender-affirming hormone levels with TDFFTC. So that's really important information that we can share with our transgender patients, many of whom really have been concerned about starting PrEP because of concerns about what it would do to their gender-affirming hormones. The other question is, what do the gender-affirming hormones do to tenofovir diphosphate concentrations in dried blood spots after 4 weeks of directly observed daily therapy? So are we seeing subtherapeutic levels? And what you can see from this study is that the levels were very similar across the different populations. Now, there are data that were published from transgender women on estradiol that suggested that the active metabolite in rectal tissue was substantially lower for women on estradiol, and that it was directly related to the level of estradiol in the blood. And so for that reason, we're still a little bit more cautious with transgender women, suggesting that they, like cisgender women, should follow the same sort of regulation about daily PrEP rather than 4 times a week PrEP. So one of the questions that arises is, what do you do for people who may have some concerns about renal insufficiency? There are multiple studies now that suggest that you might drop your estimated GFR to less than 70 milliliters per minute. If you start off with a lower GFR to begin with of less than 90, if you're somewhat older, I say somewhat older, a little tongue-in-cheek, just over 40 to 50 years of age in some of these studies, if you have lower weight or higher adherence. But I will say that the creatinine bump that was seen in these studies is often unconfirmed on repeat testing. So that can be the first thing that you do to be sure that to be sure that you don't have toxicity from TDFFTC. Creatinine reverts to near baseline levels after the trial, and rechallenge has been used successfully. Nonetheless, there was this question about, could you use TAF-FTC instead of TDF-FTC for pre-exposure prophylaxis? And so this is data from the Discover trial that Turner also mentioned briefly. Men who have sex with men and transgender women were enrolled in this study and randomly assigned 1-to-1 to either get FTAF or FTDF. Now, unlike the cabotegravir study that had 50% Black participants in the U.S., this study only had 9% Black participants in the U.S., and unlike the cabotegravir study that had 12% transgender people, this had only about 1% transgender women. Nonetheless, we did get data from this study. It may not be quite as reflective of the overall population that we are trying to reach with these studies, with these agents, but it did suggest that FTAF was non-inferior to FTDF for protection. It was not superior, but it was non-inferior, so no worse than FTDF. So what do you do in a situation where you've got 2 agents that may be effective? Well, you want to look at what the differences were in safety at 96 weeks. And what was remarkable was that the differences in safety were really very minimal. So the bone mineral density and renal function favored the FTAF arm. But in terms of bone mineral density, there was just a 1 to 2% difference in bone mineral density at the spine and the hip, and no difference in the rate of fractures between the 2 arms. So a fairly minimal reduction in bone mineral density. In terms of renal function, there was just a 4 milliliter per minute difference in the estimated GFR at 96 weeks. So while you still may want to go with FTAF in people for certainly who start off with renal insufficiency, and even perhaps people who are at risk for renal insufficiency, there were really fairly minor differences between the two. And the things that favored FTDF over FTAF were lipids and body weight, but again, fairly minimal differences, an 11 milligram per deciliter lower total cholesterol and no difference in the total cholesterol to HDL ratio, and only a 1 kilogram difference in body weight. So we're not seeing the huge differences that have been seen in some of the treatment trials in terms of body weight with TAF-FTC. So this is an infographic that my colleague Julia Marcus put together that can be useful in talking through patients about the relative pros and cons of TDF-FTC versus TAF-FTC. You can see that there's a difference in the pill size. Only TDF-FTC has been tested in heterosexuals and people who inject drugs and is highly effective in both those populations, whereas both drugs are highly effective for men who have sex with men and transgender women. And the TAF-FTC does not have a current license indication for people who are having receptive vaginal sex. So it really is not supposed to be used in women who engage in receptive vaginal sex. Again, the differences in GFR and bone mineral density are fairly minor, but support TAF-FTC for those two toxicities. For LDL and body weight, again, just a very slight preference for TDFFTC. And right now, probably the biggest difference is that TDFFTC just went generic in 2020. So some health departments and some clinics are suggesting that TDFFTC is the universal PrEP agent, and that TAF-FTC be reserved for those people who can't use it or have a strong preference for getting that drug over TDFFTC. So we have these two highly effective pre-exposure prophylactic agents, and we have this Ending the Epidemic national initiative that's goal is to get to a 75% reduction in new HIV infections in 5 years and at least a 90% reduction in 10 years. And one of the 4 pillars for achieving that is to prevent new transmissions by using proven interventions, including PrEP. And so PrEP is really one of the cornerstones of this Ending the Epidemic initiative. So how well are we doing so far? Well, we're not doing nearly well enough. The goal would be it's estimated 1.2 million Americans who may benefit from pre-exposure prophylaxis. And in terms of PrEP starts, where as of 2018, we were only 18% of the way there, doing better in men and much worse in women. We're doing better in the middle age ranges and much less well in the youngest age group, as well as in the oldest age group. But the youngest age group that may be at really substantially elevated risk, only 11.4% were covered with PrEP. Here's what's very disturbing. We see that there are these substantial racial and ethnic disparities. 42% of white individuals who are recommended PrEP have started on PrEP, whereas it's much lower, 6% for Black African Americans, and for Latinx, 11%. And so we really need to find ways to make PrEP both desirable and increase the uptake and make it accessible for people of color, in particular African Americans and Latinx communities. And then if you look at the geographic distribution, the darker colors here show lower levels of coverage. And we know that over half of the new infections in the United States are occurring in the southeastern United States. And that's where rates of PrEP uptake are substantially lower, particularly as there has not been Medicaid expansion in some of those areas. So it's not just about taking up PrEP, but it's also about staying on PrEP. So this is about PrEP persistence in a national sample. The blue lines show the people who had initiated PrEP, so that's the 100%. And then they looked at what about persistence at just 1 year in orange bars and at 2 years in the gray bars. And you can see that there are these dramatic declines across all age ranges, but particularly with the younger age populations. Persistence has been very low. And if you look at that for women versus men, you can see again that we're doing less well with women with much less persistence, only about a third of women persisting on PrEP at 1 year. We also know that COVID has interrupted PrEP uptake and PrEP, both PrEP new starts. These are data from the Fenway Community Health Center. PrEP new starts were down 72%, and PrEP refills were lapsing, and that increased by 191% from January to April of last year. So what we've seen, and these are data from the Magnet Sexual Health Clinic in San Francisco. The orange line are the PrEP prescriptions, and you can see again this cliff that people dropped off of when we started with the COVID pandemic. Now, what we've been seeing is some reversion back to higher levels, but still not at the levels that we saw prior to the COVID pandemic. And so we do need to find ways to get PrEP to individuals despite COVID when clinics are closed or people are not wanting to come into clinics. So let's talk more broadly about the top reasons why people who may benefit from PrEP don't take or stop PrEP. And I divide these into 5 different buckets of reasons. One is about sexual risk, one is about access issues, concerns about medications, stigma, and interfering life events. For some of these, there's going to be a consistent problem regardless of the type of PrEP that's used, regardless of whether it's daily PrEP or on-demand PrEP, an oral pill or an injectable. And that's true, for instance, if you've got low self-perceived risk, you may not want to take PrEP. If you don't have providers or there are cost or insurance barriers, that may affect all different kinds of PrEP modalities. Medical mistrust may be a problem regardless of the type of PrEP that you may have access to. And concerns about being labeled as high risk and stigma are not going to be addressed just by having a different method of PrEP available necessarily. And life events, again, can interfere in either situation. But there are some problems that could be alleviated by different PrEP modalities. So, for instance, if you have infrequent sexual contact, using an on-demand regimen may be more appealing. If you have difficulty adhering to the visit or lab schedule, then some of these longer acting agents that require less frequent visits or less frequent lab schedules may be desirable. There may be concerns about specific side effects with either TDFFTC or TAF-FTC, or you may just not want to take a daily pill, in which case having an on-demand pill or an injectable or an implantable or one of the other agents may seem more desirable. And there are privacy concerns that people have that can sometimes be alleviated depending on what the different PrEP modality is. So let's talk then next about on-demand approaches to PrEP. And I want to start by just reminding us about PEP, or post-exposure prophylaxis, because it's really underutilized. So these were data that came from 10 of the U.S. cities with the greatest overall HIV prevalence. And you can see that if you compare HIV providers to non-HIV providers, 82% of the non-HIV providers were aware of post-exposure prophylaxis, but that means 18% were not aware, so nearly 1 in 5. This is now decades post the recommendations for non-occupational post-exposure prophylaxis. And if you look at whether or not PEP has been prescribed by individuals, only about 2/3 of the HIV providers and fewer than 1/4 of the non-HIV providers have actually provided PEP. So it does just remind us that we should counsel our patients that if they do have an unexpected exposure to HIV, that they can take post-exposure prophylaxis, particularly if the earlier the better after exposure, but up to 72 hours after the exposure, they can still take post-exposure prophylaxis. So the other on-demand regimen that has received a lot of attention is the Ipergay regimen, which is also sometimes called 2-1-1. And it's called 2-1-1 because you take 2 pills or a loading dose 2 to 24 hours before sex, 1 tablet 24 hours after that, and another tablet 24 hours after that. So it's 2-1-1, but it could also be called 2-1-1-1-1 because if you have more sexual activity, then you just take daily pills until 48 hours after the last sexual exposure. And if you've stopped and you're getting ready to restart, if the last pill was taken within 7 days, then you don't need a loading dose. You only need a single pill to start. So it's a little bit complex to describe, but that's why we use the term 2-1-1, so that they remember it's 2 pills 2 to 24 hours before, 1 pill 24 hours each after that, and then you continue taking pills until 48 hours after your last sexual episode. And again, if you restart, you don't need the loading dose unless it's been at least 7 days since you took your last dose. So how well did this do? Well, in the randomized control trial, there was 86% efficacy against a placebo control, and in the open label extension, a 97% relative reduction versus placebo in the risk of HIV acquisition. The issue is that these were individuals who were still having relatively frequent sex. And so if you're having sex once a week, then you're taking 4 pills around that time. So that's 4 pills a week, which I've said is essentially equivalent to taking 7 pills a week for men who have sex with men. And on average, the men involved in this study were taking 18 pills a month, so a little more than 4 pills a week. So the question arises, is it effective if you have sex less frequently than that? And so there was an analysis of the IPERGAY study looking at people with less frequent sex, and what you can see is that there were no infections in the TDFFTC arm of people who were not taking, who had less frequent sex but were taking TDFFTC, whereas there were 6 infections in the placebo, a 9% incidence rate, and so really a substantial reduction. So it does work even if you're taking PrEP very intermittently because you've got much less frequent sexual activity. So if you do a head-to-head comparison of 211 PrEP against daily PrEP, who can use it? Well, 211 PrEP has only been studied in men who have sex with men, so it's only currently recommended in that population, whereas daily PrEP can be used by anyone. TDFFTC is the only drug that's been tested in 211 PrEP, so you don't want to use it with TAF-FTC, but daily can be either TDFFTC or TAF-FTC. Chronic hepatitis B infection can trigger a flare where if you use 211 PrEP, you need to plan at least 2 hours in advance, and it's not forgiving of missed doses. So 211 PrEP is been endorsed by the WHO, not yet by the CDC, but it will be hopefully in the near future. And then there is tenofovir douches that are being currently evaluated as another on-demand method. You can see here that you can get quite high levels in the colonic cells, higher than daily oral PrEP or less frequent than daily oral PrEP. And you can see that in this non-human primate challenge study, it did even better than oral daily PrEP. So I'm just going to close by briefly mentioning the long-acting agents that you've already heard about. Cabotegravir is superior to TDF-FTC for women and men. It's currently being used as an IM injection formulation, but it's being considered for an implant and a microarray patch. There are questions about why there were breakthrough infections in the trial. Will the tail provide long-lasting protection, or will it be too low and actually then for protection but select for resistance? By whom will this be used? Who's going to want this? And how, where, and by whom will it be administered? And we talked a little bit about that in the last talk. Islatravir, this nucleoside reverse transcriptase translocation inhibitor, is being evaluated as a monthly pill for men who have sex with men and transgender women in an efficacy study, and it will also be studied in cisgender women in a separate efficacy study. It's going to be evaluated as a yearly implant as well in the future, and it could be possibly combined with contraception. Lenacapavir is a capsid inhibitor that's being evaluated as a semi-annual subcutaneous injection for men who have sex with men and transgender persons in one study, and in cisgender women in a separate study that's also got an arm that's going to look at TAF-FTC so that we'll finally get an answer as to whether or not TAF-FTC is protective for cisgender women. And then I just want to close by mentioning dapivirine vaginal rings. This is an NNRTI that was found to have approximately 30% efficacy in RCTs and approximately 50% efficacy in open label extension studies. It's recently been approved by the European Medicine Agency as well as endorsed by the WHO. And next generation products may allow for less than monthly but sort of quarterly vaginal ring insertion, as well as combinations with contraception. And so in conclusion, we really have highly effective PrEP and PEP options with more under development, and I didn't even talk about some of the PEP options that are currently under development. Cabotegravir long-acting intramuscular is the latest product, but we have a robust pipeline of monthly pills, semi-annual subcutaneous injections, annual implants, and possibly vaginal rings. There are challenges with uptake and persistence in all populations, but particularly for youth, people of color, women, and people who inject drugs. And long-acting agents will solve some, but not all of these problems associated with daily pills. But we need to offer choice and provide support tools to keep people on PrEP during periods of risk. Thanks so much, and I'm happy to take questions.
Great, Susan. Thank you very much. Great review. And we have a number of questions that are coming in. Remember to use the Q&A function. Before I start taking questions from the audience. I'm just curious myself. San Francisco has made a big effort called Getting to Zero, multi-pronged effort to reduce transmission and death from HIV. What's happened with that campaign with COVID it looks as though some aspects of it are in trouble.
It's true. We've actually we saw a really dramatic decline both in PrEP uptake and as well as in testing, HIV testing, right, and as well as in viral load monitoring. We have seen a rebound back towards normal, but it's still about 10% lower levels of HIV testing and viral load testing than what we saw before. So people are trying to find other ways around delivery of PrEP to people's homes, and finding other ways to be doing monitoring and clinic visits for patients in the time of COVID.
Right. And we've all seen a dramatic increase in new strategies of patient contact, whether it's telephone or video visits.
Right.
And there are questions really on the implementation side. The recommendation is they come in every 3 months, in person, lab, et cetera. Is that realistic, and what are people doing in terms of changing that kind of follow-up now that we have the concerns with COVID?
Yeah, so there are different ways, different strategies for trying to address that with home prescription deliveries and home HIV testing. There is a program called Take Me Home that you can look up online. It's working with health departments around the country to be able to do home testing of HIV and even creatinine levels and home screening for STIs. So that, I think, is going to become a more desirable approach in the future.
Great. Question about where is a good information source? Black and Latinx men who do not identify as MSM report only female sex partners. Is there a good source for PrEP information for those people? That's
a great question. There are lots of places to get good information about PrEP, and I think the AVAC, the AIDS Vaccine Advocacy Coalition, there's a PrEP tracker and there's a lot of PrEP information on that website. It's not specifically targeted towards African-American men who have sex with men, or Latinx men who have sex with men, or people who are not necessarily identifying as men who have sex with men or gay. And so I think that what you need to look at is within hopefully within your own cities, we've tried to launch different kinds of campaigns about PrEP for different populations, and so looking to see what other cities have online that may be available to people is one approach.
So another really great question is respond to concern that low PrEP uptake is just that we're not doing a very good job of creating a LGBT kind of friendly environment in our healthcare system. PrEP is only one aspect of what that complex set of communities needs. Is that something you're thinking about?
I think that's absolutely the case. It really is, and I think that one of the things that we can all do with our patients, so I think that we need more LGBTQI friendly services for our patients, but also we need to be offering PrEP. We need to not forget about women who may benefit from PrEP. And so one of the approaches that some people are using is to just educate all of their patients about PrEP, to say, we have actually a daily pill that can prevent HIV infection. Is that something you'd like to hear a little bit more about for people who may potentially be exposed to HIV? And then it gives you an entree without necessarily having to identify somebody as falling into some preordained category that indicates that they may benefit from PrEP.
And then quickly, real world data on why people choose 211 versus daily PrEP. Is that? Yeah,
in fact, in the time of COVID, a lot of people have actually converted from daily PrEP to 2-on-1 PrEP, but people go back and forth between the two. And I think in general, people go to 2-on-1 PrEP when they're having less frequent sexual activity, as long as they can plan 2 hours in advance. And so people will be very creative and, for instance, pop a pill first and then wait 2 hours before they go online to find on a hookup site to find a partner, or they may open a bottle of wine first and to spend a little time beforehand. I've heard all kinds of strategies that people use, but I think it's really for people who can plan ahead and people who are having less frequent sexual activity.
Have STI rates changed after the pandemic hit us?
Unfortunately, we've seen, we know that STI testing went down for a while. Unfortunately, we've seen still high rates of STIs despite COVID. And I think there was an initial decline probably as, people were sheltered in place more. Yeah. But then that only lasts for so long. And so there's a real concern that if we're delivering fewer services and doing less STI screening, that we might have more untreated STIs out there.
Well, thank you very much, Susan. That was a brilliant talk. Several people commented on how great your talk was. So thank you very much.
Thanks.
And we now go to a break. What we found is that when we're trying to do, several hours of Zoom, people do want to kind of get up and stretch, and they should. It's healthy. So we'll take a 30-minute break and just hang in there, and we'll let you know when we're going to start. Thanks a lot, everybody.